This is Michael Lawless. Thank you for allowing me to present our research entitled Cervical Alignment and Patient-Reported Outcomes in Posterior Cervical Fusion, Longitudinal Comparative Cohort Study. We have no relevant disclosures for this talk. Maintenance of horizontal gaze and a neutral head position have shown promising but mixed results for improved patient-reported outcomes following posterior cervical decompression and fusion, not for deformity correction. However, prior studies were mostly limited by underpowered analyses. The objective of our study was to determine if normative cervical sagittal parameters independently impacted patient-reported outcomes following multi-level PCDF. To do this, we performed a retrospective comparative cohort study of prospectively collected data from period 2016 to 2020 at Ascension Providence Hospital with multiple surgeons. Inclusion criteria consisted of consecutive patients undergoing PCDF of at least 4 levels spanning the cervical-thoracic junction for a degenerative indication. All patients underwent a lateral mass, thoracic pedicle screw and rod construct instrumentation. Prior to placement of the rods, the head is realigned in a more neutral position. No facetectomies or osteotomies were performed in included patients. Our comparators were the 1-year postoperative standing x-rays, in which we dichotomized patients into normative and non-normative cervical sagittal parameters. Our outcomes were the 1- and 2-year patient-reported outcomes. We calculated the minimum clinically important difference, utilized univariate analyses, multivariable logistic regression model, patient-reported outcomes as the dependent variable. Covariates included in the model consisted of age, smoking, baseline PRO, and baseline X-ray parameter. Our results in our univariate analyses, we found that VAS arm, significantly more patients met the MCID for VAS arm when the cervical sagittal vertical axis was less than 4 centimeters, which is normal range. We also found that significantly more patients achieved MCID for VAS neck when the McGregor slope was less than 20 degrees, which is a normative value. Our multivariable regression model showed that for every 1 degree increase in the patient's McGregor slope, there was a exponential decrease of 0.56 for the odds of achieving MCID for VAS neck. In conclusion, in our series of 144 consecutive patients who underwent multi-level PCDF, we found that patients with a normal cervical sagittal vertical axis of less than 4 centimeters had a significantly increased chance of achieving MCID for arm pain. Patients with a normal McGregor slope, which is a surrogate for line of sight, had a significantly increased chance of achieving MCID for neck pain. And again, that's for every 1 degree increase in the McGregor, so there's a 0.56 decrease for achieving MCID for neck pain. Our findings are consistent with physiological principles described by LaFage and colleagues that the natural head position is based upon a balance between minimal energy expenditure, i.e. a non-forward head position, and horizontal gaze. And achieving these normative values can lead to improved patient-reported outcomes and should be considered when performing these surgeries. Thank you for your time and attention.